Good morning. Now, Mr. McGregor, I think we're able to begin.
Yes, my lord, the next witness would be Dr. Donald Inverarity.
One small technical problem. I have not brought my notebook. True. If you go into my room, it's the thick notebooks on the upper shelf. They're numbered 1 through to 4, I think, so it's obviously 4. Sorry about that. All right, thanks very much, Joe. Right, well, I think we've managed to address this technical problem. And is Margot bringing in Dr. Inverarity? Yeah, okay. Good morning, Dr. Inverarity.
Good morning.
As you understand, you're about to be asked questions by Mr. McGregor, sitting opposite. But first, I understand you're agreeable to take the oath.
Yes, I am.
Sitting where you are, can I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
and
nothing but the truth.
nothing but the truth.
Thank you, Dr. Inverarity. Now, as has probably been explained to you, we'll be sitting between 10 and 1 o'clock, and we'll take a lunch break. We usually break for coffee about 11:30. But if for any reason you want to take a break during your evidence, just give me an indication and we'll take that break. Please feel that you're in control of the position. The other thing I would like to say is that it's quite a big space. And I have a hearing problem. I wear hearing aids, and I'm very conscious that I sometimes miss things. So can I ask you to speak a little bit more slowly and a little bit more clearly than you would in normal conversation? I mean, I appreciate it's rather difficult, but as I say, everyone wants to hear you, and I certainly do. Thank you. Mr. McGregor.
Thank you. You are Dr. Donald James Inverarity, is that correct?
That is correct.
And you've provided a witness statement to the inquiry, which, for the benefit of court participants, is available at pages 84 to 207 of Bundle 3 of the witness statement bundles. The content of your statement is going to form part of your evidence to inquiry, but you're also going to be asked some questions by me today. if at any point you want to refer to your statement, please just do let me know. There should be a copy available for you. In relation to any documents that I want you to look at, those should come up in the screen in front of you. If for any reason you can't see them, if you can just let me know.
Okay.
So before we begin, I understand that there's one correction that you'd like to make to your statement. Is that correct?
Yes, it's in paragraph 9 in relation to guidance that was in place when
It's probably easiest if we just bring it up and then I can you can let us know just exactly what you want to change. So I think if we could bring your statement up, which is in bundle 3 of the witness statements, look to page 99 and to paragraph 9. So I think it's page 87. Was there a correction you wish to make within paragraph 9?
It was in relation to the guidance that was in place when I was undertaking training in healthcare ventilation. In England, the guidance was HTM 0301, and in Scotland, it was still SHTM 2025.
Okay. So at the time that you were undertaking training in relation to the built environment, the relevant guidance was HTM 0301 in England and Wales and SHTM 2025 in Scotland, is that right?
That's correct.
Thank you. I could just begin by asking you some questions about your qualifications and career. You set that out within your statement, but you have been employed by NHS Lothian since 2014, is that correct?
That is correct, yes.
And you're a consultant medical microbiologist and lead infection prevention and control doctor, is that right?
That is correct.
And you've held that role since 2015.
That is correct.
Having undertaken similar roles with other health boards, including NHS Lanarkshire.
That is correct.
And you tell us within your statement that your areas of expertise include infection prevention and control, particularly in relation to healthcare associated infections arising from water and ventilation, is that right?
That's right.
We'll come into the detail in a moment, but could you just explain in general terms what expertise you have in these aspects of the built environment?
So it's expertise that's come from dealing with a number of incidents in various healthcare buildings where there have been water contamination events with Legionella, with Pseudomonas aeruginosa, that are two bacteria that commonly affect water systems. I have experience of being involved in design of refurbishment projects and also new build projects. So in NHS Lanarkshire, around 2010, I was involved in the design and then the build of a refurbishment of an adult haematology unit, and also involved in the design of a new intensive care unit for the hospital and a plan to refurbish operating theatres. More latterly in NHS Lothian, I was involved in the Children's Hospital, and since then I've been involved in design stages for a new eye hospital and treatment centre, but have been involved in various refurbishment projects as well.
So in addition to we'll come on and talk about what your day-to-day role involves, you've also been involved in some major new build hospital projects during your career.
Yes, I have.
And is that usual for an infection prevention and control doctor, or is this just happenstance that during your career certain health boards have been doing these major projects?
For myself, it's really been driven by where I was working and plans that were in place for those particular facilities. It is becoming, I think, more common for infection control doctors to be able to function with those skills.
Because the inquiry's heard evidence that often during the career of an infection prevention and control doctor, a new build hospital might either be a once in a career or perhaps never in a career event. Speaking to colleagues, has that been their experience until relatively recently?
Yes, I would agree with that. It does really depend on the health board that you're working in and the age of the estate that's present. And larger health boards generally tend to have more building projects than the smaller health boards.
I think you'd mentioned that your view was that infection prevention and control, is that teams as opposed to simply the infection prevention control doctor were becoming more involved in the design of projects. Did I pick you up correctly?
It's not just limited to the infection control doctor role, it's the entire team that are involved. And
is this something, just think through your career from the 1990s onwards, is this something that has been developing gradually over time?
Yes, my career in microbiology really began around 2002, and although there was within that training a limited amount of expectation of understanding of the healthcare built environment, it was limited really to operating theatres or isolation rooms, and a little bit about water systems and risk from Legionella. There were reports around that time from microbiologists who were horizon scanning as to what the infection control doctor role would entail in the future, and it was very much more around about incident management, dealing with outbreaks of infection, resolving those, surveillance of infections that were causing significant harm, like Clostridium difficile, Staph aureus, bacteremias. And the built environment was not really on the horizon at that stage. I think by around 2010, there was more of an awareness of the built environment being an issue that infection control practitioners would need to have an input into. But that often was more in the context of being able to ensure that the area could be kept clean and maintained, and that infection risk could be engineered out of fixtures and fittings rather than dealing with integral systems within the building, critical systems like ventilation system. There has been an awareness of that over the years, and various people within the field have focused on that. But for the generalist, it was less of an issue.
So you obviously had a particular interest, as you tell us from your statement, and you had the practical experience from working at NHS Lanarkshire. But should the inquiry understand really the idea of infection prevention and control in the built environment throughout the early 2000s up to I think about 2010, you said there's a general awareness, but not perhaps a specific focus on that from the infection prevention and control angle. Is that correct?
Yes, it was more of a niche area that some people would explore more and develop skills in, but it wasn't mandatory, and it was by personal choice.
Okay. And from 2010 onwards, developing discipline is really the science and understanding around about infection prevention and control in the built environment. Is that still an emerging area of science and discussion amongst professionals?
Yes, absolutely at the moment, and the pandemic has had a lot to do with that. I think understanding of how infection travels by air and the role of ventilation systems has accelerated a lot because of the pandemic, but research has been going on since the mid-20th century regarding designs for operating theatres, for instance.
Mm-hmm. And again, we'll come on and perhaps look at some more specific documents, but you identified the fact that there had been some research, particularly in relation to operating theatres. The inquiries heard evidence that, for example, in the 1970s, Dr. Lidwell was doing certain modelling based effectively on scientific probability in relation to air changes in operating theatres. Is that the type of analysis that you were aware of?
Yes. That work is fundamental to the design still today of conventional operating theatres. And through the 70s, there was work on design of ultra-clean operating theatres as well by different people.
And again, we'll come on and look at some of the documents, but certainly the inquiry's seen documents suggesting that really right through the early 2000s up until 2019, there was a view amongst a number of professionals working in infection prevention and control in the wider NHS that really there just wasn't enough research and robust evidence around about issues relating to ventilation in healthcare. Was that your understanding?
I think there was robust evidence. I think the application of it was changing as healthcare developed and patient risk profiles were changing, interventions were changing, the way surgery was being performed was changing. So it's never a static landscape, but a lot of the principles were fairly well established.
And then you mentioned obviously the COVID-19 pandemic. Has that almost shone more of a spotlight onto the area and the need perhaps for more research and understanding in this area?
Absolutely. I think the potential consequences of suboptimal ventilation are much clearer, and also general understanding of the role of ventilation is much more widespread from the general public, and also through staff in healthcare. Having a conversation about ventilation systems pre-pandemic was a very different conversation to having a conversation post-pandemic.
And in terms of some of the issues the inquiry is interested in are air changes per hour and pressure regimes. Are you aware in the period, let's talk post-2019, of ongoing research and analysis in relation to those types of issues in the built environment for hospitals?
Yes, particularly in the application of what's referred to as fallow times, which was during the pandemic trying to identify how long you would have to leave a room empty before staff could safely re-enter, particularly either cleaning staff or the next patient if you're in a dental surgery, for instance. So there was work that's now referenced in the National Infection Control Manual, undertaken in conjunction with Leeds University to really determine in a clear table how long you would need to leave a room fallow or empty for virus to settle, based on time and the air change rate per hour.
So now there is some guidance you're telling us in terms of how long a room would have to be left, how many air changes per hour would be required. Obviously, one of the issues the inquiry is interested in is critical care spaces. In broad terms, what does that research tell us?
So the parameters for critical care really haven't changed for a long time, really. 2007 and HTM 0301 in terms of air changes and pressure cascades. I think what has changed is an awareness that not all critical care areas deliver that if they were built during the 20th century. And through the pandemic, there have been attempts to try and augment ventilation within those spaces to improve or to minimise the risk of transmission of COVID, particularly with the use of devices that are referred to sometimes as air scrubbers.
And again, we'll come on and look at this in more detail, but obviously the guidance, current published guidance, both Scotland and England, says that for critical care areas, that the standard and the guidance is positive pressure and 10 air changes per hour. In your view, is that best practice guidance, or is that really the cut-off point that you need for a space to be safe within critical care?
So I consider it as best practice guidance. I think it's difficult to be certain about safety because safety is a destination that is difficult to reach in healthcare. And what may be considered safe for one patient may not be safe for another, even though they're in the same area. So in critical care, maybe if I can illustrate that, if I had a room with 4 beds and a patient is admitted, say, for instance, unconscious from an overdose, and then develops a fever and is found to have influenza, the 3 other patients in that room will have exposure to influenza. If, for the sake of argument, one of those patients is on drugs for treatment of something like rheumatoid arthritis and immunosuppressed, they have a greater probability of that exposure turning into influenza incubating and then manifesting as a new case of influenza. If, for instance, another patient in the room has a head injury and is on a ventilator, so they're breathing through a tube down their windpipe connected to a machine, they're not actually breathing the room air, they're breathing piped gases from elsewhere in tanks in the hospital. So their risk of acquisition may be less. And if, for instance, the fourth patient in the room has a bacterial pneumonia as a consequence of having had the same strain of flu, then their risk is negligible because they can't have flu again from the same strain that quickly. It's immunologically not what happens. So you've got four patients with different safety profiles based on the infection risk, although they're all in the same room and all have had the same exposure.
Just to make sure I'm understanding you correctly then, would it really have to be a multifactorial assessment that takes place in relation to what is and is not safe?
Yes, safety is a constellation of events, and infection risk is only one parameter in that. There are a whole number of other things like fire safety, safe staffing levels. Even for some patients, the colour of the walls can be an issue if there's cognitive impairment. It may exacerbate confusion. So, or there may be ergonomic issues like a trip hazard. So safety is quite a nebulous term that's got many things that factor into it, and not just infection.
So if you have a package that's set out within the guidance, for example, SHTM 0301, should the inquiry understand that if that's known to be safe and best practice, if you're stepping away from that, it's actually quite a difficult assessment for an infection prevention and control professional to make in terms of whether anything that departs from that package is going to be safe in and of itself?
Yes, it's not a binary decision between it's safe and unsafe. It's a spectrum, I suppose, of probability and safety, and it's difficult to anticipate where you may be on that until harm happens.
Your colleague, Lindsay Guthrie, described it as effectively a continuum or a sliding scale. So if we'll come on and look at this in more detail, but you take the old hospital at Sheens, it had no mechanical ventilation and no air changes, but it was generally accepted by clinicians to be safe because of the other package of measures that was put in place. Was that your understanding?
Yes. So although it didn't have mechanical ventilation as such, there were features of the architecture that provided elements of safety. There were cubicles that had doors that shut, so that only had one patient in them, and that provides a degree of physical containment. I think the largest area that had a shared bay had 3 patients, so the highest number of people that could be affected in transmission events would be, 2 really, from somebody who's infectious.
So on that scale, you would have perhaps an old Victorian hospital like Sheens, no air changes per hour, no mechanical ventilation. It could be safe, but it wouldn't be as safe as a hospital at the other end of the scale that complied with all of the guidance set out in SHTM 0301, positive pressure, 10 air changes per hour, for example.
Yes, I think that's a fair assessment.
So you could perhaps, if again, just to think about the hospital as built at Little France, 4 air changes per hour and balanced or negative pressure. On that continuum, it could still be safe in the sense of being safer than Sheens, but not as safe as the best practice guidance. Is that how the inquiry should understand matters?
Yes, I think so.
Thank you. If I could perhaps just take a step back and really ask for your views on the role of infection prevention and control. So the inquiry obviously has your statement where you talk about the role of an infection prevention control doctor, inquiries heard from Lindsay Guthrie and Sarah Jane Sutherland in relation to the role of an infection prevention and control nurse. But could you just explain in your own words, really, how the infection prevention and control team would mesh together between the doctors, nurses and other professionals working in the discipline?
Yeah, so since the events of the Veil and Leave, and the infection control team leadership has really consisted of an experienced infection control nurse, an infection control doctor, and an infection control manager. Now, in larger boards, there may be more than one person fulfilling those roles, or there may be deputies, just because the workload is too great for any one individual. But in the best examples, that team will function together as a leadership team for folk within the infection control department who may be training and not yet fully qualified in the discipline, or working with administration staff or clinical scientists. The roles that would be expected to deliver are quite wide, and no one discipline really has all the skill mix to fulfill that remit. Infection control nurses generally come from quite a senior nursing background and come with a skill set that really understands the day-to-day provision of care for patients with infection, how to get things organised on a ward and the logistics of running a ward, be that for repairs or cleaning, which is a skill set that generally I wouldn't have as an infection control doctor. The infection control doctor often brings more of a skill set from a laboratory background, and certainly from an infection management background, so more potential understanding of what the pathogens are, how they behave in particular areas of the hospital, or how they manifest as disease, and more ability to interpret laboratory data, understand its context, its limitations, liaise with other reference laboratories. There's definite overlap in the skill set as well in terms of understanding how infection is transmitted, how to identify how transmission events are taking place, how to break those transmission events with interventions, how to remove the hazard or mitigate against the hazard. And generally the key skill that we're usually called upon to deliver is outbreak management, incident management, which both involves understanding how infection transmits in a healthcare environment, but also involves other skills like diplomacy and negotiation.
Thank you. If we then think of how those skills would be utilised on a new build hospital project, is there a clear job specification for an infection prevention and control doctor as to exactly what would be expected of them on one of those projects?
No, and that, I think that's been recognised among the infection control doctors as a concern for us.
Okay. And can you just explain why is that a concern?
I think it becomes easier for there to be misunderstandings about what the role of the infection control doctor is and what it isn't. Clearly, for those of us that are in the role, we're more aware of the limitations of our training, and that isn't necessarily always clear to people in other disciplines. I think sometimes there can be misconceptions that we can perform roles that we're not actually qualified or trained to perform.
Your colleagues from the nursing side of infection prevention and control, both Sarah Jane Sutherland and Lindsay Guthrie, they said that they had real concerns that infection prevention control professionals were effectively being made to be quality control officers for new build projects, and they didn't think they had the skills, training or experience to do that. Is that a concern that you share?
Yes, I think there are certain parts of construction projects where I think having a doctor has no added value. Having a doctor attend a building site really has very limited added value. Having a doctor inspect an air handling unit to see if there's dust in it really has no added value than an estates officer. So I think, yes, there are examples where the expectations now really don't align with what we train to do.
And we'll come on and look at this in a bit more detail and slightly later today, but you'll be aware of the concept of a ventilation safety group that's been created under the latest iteration of the guidance, whereby a whole range of disciplines are going to be involved in making key decisions. Do you think that's going to be an improvement, or is that simply going to add an extra burden onto infection prevention and control professionals if they feel they're effectively being made to be the quality control officers?
No, I think it is an improvement. I don't think it's additional burden. If anything, it can provide a forum to correct those misconceptions and bring staff who have the correct skill mix to answer the questions being asked. So in particular, authorising engineers in ventilation systems, their function, their role is very much compliance, and not just in relation to infection risk, but in relation to the manufacturing process, the suitability of components, the function of the design, the appropriateness to healthcare. And those are skills that the infection control team just simply don't have. But the need for them is sometimes projected onto the infection control team. So having an authorising engineer present to speak to those issues is a distinct advantage.
So you mentioned in your evidence there's a lack of clarity in terms of what's expected of you as an infection prevention and control doctor, perhaps a misunderstanding in relation to other members of project teams as to what infection prevention and control professionals can and can't do. Just at a practical level, what would be helpful to infection prevention and control professionals to try to provide that clarity? What could be done to improve the situation?
I think being clearer as to what is in scope and what's out of scope with regard to specific stages of a building project, and when it's out of scope, being clearer whose job best aligns with that task.
Thank you. I'd just like to ask you a few further questions really about the training that infection prevention and control professionals would receive in relation to the built environment. Lindsay Guthrie gave evidence to say that effectively if you want to become an infection prevention control nurse, there's further training that you'd have to do, but none of that training involved the built environment in terms of ventilation systems, water systems. Is there any mandatory requirement for training in the built environment to become an infection prevention and control doctor?
So the training really begins before you become a consultant. The curriculum for the FRC PATH exams includes an expectation that as you complete that training in microbiology, virology, you will have a skill set, a generic skill set in infection control principles. And that, as I said earlier, includes things like operating theatre design and water systems. But it is a generic skill set. Passing those exams is necessary to become a consultant in the UK and to appear on the GMC specialist register as a medical microbiologist. So having got to that stage, you already have some basic knowledge. It's within the grounds of possibility that you move from, I've just completed training, I'm a new consultant, I get my consultant post, and suddenly I'm in the infection control doctor post, and have no additional qualification or training or experience in issues in the healthcare environment. So may understand some of the basic principles, but never had to have applied them in a real-world setting, unless during training you've had the benefit of shadowing people who are involved in that activity. So there are limitations, and there's no obligation to partake in specialist training at consultant level as a medical microbiologist. For those of us who are infection control doctors, I think the only expectation on us is that when we have our annual appraisal, we demonstrate that we've been active in continuing professional development in the field of infection control. But it's that vague. There's nothing specifically about the built environment. That would be a personal option.
So there could be a scenario whereby there's someone who is newly qualified as an infection prevention and control doctor. It just so happens straight after that basic training that they are the infection prevention and control doctor for a major new build hospital. But that individual wouldn't be required to undergo any specific mandatory training in relation to specialist ventilation systems or specialist water systems before they worked on that project.
That's a potential scenario, yes.
Do you think that's a potential problem in the system, a skills gap, that if someone could be put in that position of taking on that role without some form of specialist training?
Absolutely, yes.
So again, I'd be interested in your views, Dr. Inverarity. How could that be improved, just in terms of suggestions or recommendations as to how that could be made better? What specific training do you think an infection prevention and control doctor would benefit from if they were working not just on one of the small generic refurbishment projects, but one of these large major hospital new build projects? What would they benefit from?
So there are courses run within the UK that would cover that knowledge gap. They are expensive and residential usually, but they do exist. And so participation in such a training or equivalent training that's hands-on rather than theoretical or online, I think is beneficial. But also there's not a lot that studying in a kind of simulated theoretical environment. There's limitations to what that can teach you compared to being involved in the actual process, and more of an apprenticeship model of shadowing folk that are already involved in projects with more experience.
So again, just so I'm understanding correctly, it's almost unrealistic, even if someone had the academic training, to expect someone simply to go from having sat in a classroom to have all of the skills and knowledge that would be required for one of these large healthcare projects. Really, the type of training someone would need would have to have been from working on these types of projects.
Yeah, I don't think it's a necessity, but it would certainly be beneficial and make the process much less daunting.
Thank you. I'd now like to just look at some guidance with you that's been published in relation to infection prevention and control. And if we could begin with Scottish Health Facilities Note 30, please, which is at Bundle 13, Volume 3, at page 464. So Bundle 13, Volume 3, page 464. And that should be the October 2014 version. Do you see that?
Yes, I do.
I just noticed, Lord Brody, we're having some difficulty with the documents being displayed on the screens. I'm not sure if that's a... I'm not sure if that's a problem for any core participants that are following, but it's certainly not coming up in the large screen there.
Right, we don't have it on the screen at the moment.
I have it on my screen, but I can't see it on the large screen in the room.
Right. Drew, what's the, are we planning to display documents on the screen? Okay, I mean, this should be on screen. Right.
Perhaps while we're just waiting for the technical issues to be resolved, could you just explain in your own words, what is this document we're looking at and what's its purpose?
So SHFN 30 is more commonly referred to as HiScribe, the Healthcare Associated Infection System for Control of Risk in the Built Environment. It's essentially a way of making sure that people think before performing activities that might cause harm in healthcare settings with regard to refurbishments or other aspects of building. It sets out to identify whether what's intended to be performed is fairly minor, such as replacing a sink, or fairly major, like demolishing a building, and also look at the risk profile of the patients that might be affected, whether that they're fairly well in, for instance, a mental health setting, in an outpatient setting, or whether they're very susceptible to infection, such as in a bone marrow transplant unit.
Thank you.
My understanding, Mr. McGregor, is that this morning, core participants will be able to access on their own laptops. The witness and I have access to the screen, as I hope you do.
I do, Lord.
Right. But we're not using the large screens this morning.
Okay, thank you. But I think you were just explaining that really this would be, I think you said it was an introduction to HiScribe, and that's effectively a tool that would be used in relation to projects involving the built environment in hospitals. Is that right?
Yes, it's mandatory in Scotland.
Thank you. And if we could just look on to page 468, please. It's just the first full paragraph below the box. You'll see the wording beginning, scrutiny of this guidance. Do you see that?
Yes, I do.
It says scrutiny of this guidance will highlight the frequent use of the word partnership. Successful use of HiScribe requires participation and cooperation, particularly between estates and facility staff and infection prevention and control teams. Do you see that?
Yes, I do.
Can you just explain in your own words, what's your understanding of this requirement for partnership working?
So, in a building project, no particular discipline has all the skill sets necessary for a successful outcome. And it really seeks to facilitate bringing those disciplines together using a common tool to assess risk together. Because what may be identified from a clinician or from somebody working in infection control may not be immediately apparent to somebody with an estates background, whereas other risks would be immediately apparent to estates team and not necessarily apparent to clinical teams. So it's just a means of bringing people to work to a common goal.
And do you think that was well understood in the period up to 2019, that really this wasn't just an infection prevention and control document, this was aimed at a much wider audience, estates and other disciplines?
Yes, I think it did depend a little on where you were working and how it had been adopted, but generally it had been enforced through various chief executive letters since about 2007 that this was a mandatory process that must be followed.
So it certainly should have been understood within the wider NHS?
Yes.
Thank you. And if we could look on to page 470, please, to paragraph 1.4. if you look at around 4 lines down, you'll see a sentence swearing for HAIs to be reduced. Do you see that? Page 470, paragraph 1.4, 4 lines down, for HAIs to be reduced.
Yes.
For HAIs to be reduced, it is imperative that infection prevention control measures are designed in and IPC risks are designed out at the very outset of the planning and design stages of a healthcare facility, and the input continues up to, into and beyond the final building stage. Do you see that?
Yes.
So again, should the inquiry understand that if a health board was setting its brief for what it wanted for various spaces within the hospital, infection prevention control should be involved in those types of discussions?
Yes.
And if a health board was changing its brief for certain areas within the hospital midway through a project, is that the type of discussion that all these disciplines, including infection prevention control, should be involved in?
Optimally, yes.
Whenever you say optimally, what are the risks that you'd be taking? Just say you start a project, you get halfway through and you decide that you're going to change your brief for certain spaces within the hospital. If you don't involve all of the disciplines set out within SHFN 30, what risks are you taking?
Well, there's more opportunity for misconceptions. I think having the clinical team, the infection control team, and the building team, estates team in the same room, or certainly in the same discussions, breaks down misconceptions. Certainly experienced myself where my perception of what would happen in a room doesn't actually align with the clinical teams, and therefore there would have been a potential risk that something unsuitable would be built. Whether unsuitable would lead to being unsafe is a different matter.
So an opportunity to ventilate what is and isn't suitable and what is and isn't safe. Is that fair?
Yes.
If I can ask you to look on, still within this document, Bundle 13, Volume 3, to page 471, and at paragraph 1.6, we'll see that the various stages of the scribe process. And you see there, the fourth bullet point, development stage 4, pre-handover check, ongoing maintenance and feedback. Do you see that?
Yes.
So again, should we understand from the literal reading of the wording there that there should be a check done in terms of the process before the hospital is formally handed over from the contractor and accepted by a health board?
That's what I take from pre-handover check.
And again, just looking at matters from your perspective as an infection prevention control doctor, if there was a new build hospital and this stage 4 was simply skipped, the health board just accepted the hospital before it did the stage 4 high scribe check, what would the types of risks that the board would be undertaking by that course of action?
So there would certainly be a potential infection risk, but there may be other risks such as fire risks. Essentially, that stage 4 in the high scribe is related to infection risk because it's healthcare associated infection that it's really tailored to. But that is the final safety check, really, before being assured that it's an appropriate environment for delivery of healthcare, and before allowing patients and staff to be exposed or in that area. I think without it, you run the risk of not picking up snagging issues, and those may or may not lead to infection issues over time. It may not be that they're immediately apparent at the time of handover, but may develop over the lifetime of a malfunctioning critical system.
In simple terms, if you didn't do the stage 4 check before you accepted the hospital, would you be accepting a hospital not knowing whether it was or was not safe for patients?
With relation to the high scribe, it's really intended for infection risk, but you would be accepting somewhere without knowing where there may be hazard.
And if a health board that you were working for came to you for advice and said, we're thinking of just skipping the stage 4 high scribe process and just accepting the hospital without going through that procedure, is that something you would recommend?
Absolutely not.
And again, you say absolutely not, so you seem very clear in your thinking. Again, just in simple terms, why not?
Because it's potentially missing your last chance of being assured that the area is safe.
Thank you. The next document I ask you to have in front of you, please, is Bundle 13, Volume 3, at page 553. And if we look on to page 554, you'll see that this is an earlier iteration of SHFN 30, this time from June 2007. Do you see that?
Yes, I do.
And during the course of your career, have you had cause to look at this document at any point?
Yes, it was the current guidance when I worked at Monklands Hospital.
And again, I won't take you through it, but again, it's in very similar terms in many respects to the guidance that we looked at, talking about a multidisciplinary approach. Is that correct?
Yes, in terms of multidisciplinary approach, yes.
And if I can ask you to look on to page 573, please. You see section 5's headed up risk management. And if we look to paragraph 5.3, you see it says, to avoid mistakes and pitfalls, the project team must consider issues including, first bullet point, how the product, equipment, room or clinic be used. Do you see that?
Yes.
So again, to the inquiry, understand this concept of risk, it's not as simple as saying it's the same risks for every space and every patient. You really need to know the specific room and the specific clinical use that it's going to be put to be able to try to calibrate the risk profile.
Yes, because that may be different for different people, or it may be different depending on how the room's used through the course of a day.
Thank you. And then if we look at the second last bullet point, you'll see that it says, what are the standards and guidelines from architectural and engineering bodies, government departments and accrediting agencies? Do you see that?
Yes.
So again, should the inquiry understand that what this guidance is telling you from at least 2007 is that the multidiscipline project team are being told you need to have on your radar published guidance from engineering bodies, government departments and accrediting agencies if you're working on a new build hospital project?
Yes.
If we look over the page onto page 574, you'll see that there's a bold heading, Common Errors, 5.5. Common errors in design and construction adapted from Carter and Barr 1997 due to inept or non-existent risk management include, and then if we look to the second bullet point, incorrect air turnover and airflow patterns. Do you see that?
Yes.
So if we just think back to whenever you were working on the Monklands project, would you be aware at that time that a common error could be incorrect air turnovers and airflow patterns if you're not following the published guidance?
Yes.
We don't see these common errors listed in the 2014 iteration of the guidance. As someone that worked in this space, had those types of common errors, had they really been ironed out by 2014? Is that why we don't see it mentioned in the later iteration of the guidance?
I don't know why they're not mentioned in the later guidance, but they certainly hadn't been ironed out.
So from your understanding as someone who worked in this space, certainly if you're working on a project from 2014 onwards, it would still be a common error that you could trip up on air turnover, airflow patterns if you didn't have appropriate risk management procedures in place.
Yes, and those risks are highlighted in other papers and documents from that time. There was a paper produced by the Association of Medical Microbiologists in 2006 that lists a much wider range of common errors in building projects by Jane Stockley and 2006 on building hospitals. And the CDC in the USA, the Centre for Disease Control, 2003, have published a very comprehensive guidance document on infection control in the built environment, and many of these issues are featured in that document.
We'll come on and look at this in more detail in relation to the project, but while we're just looking at this at the minute, if it's a known common error that you could potentially get air turnover and airflow patterns wrong, the inquiry's heard evidence that effectively on the project for the Royal Hospital for Children and Young People, that the Health Board's brief effectively started off life that it was going to be positive pressure for critical care rooms. There was then a decision taken on behalf of NHS Lothian that really what it wanted was balanced or negative pressure, 4 air changes per hour. And then, as we all know, that's then changed back to positive pressure and 10 air changes per hour. How did that come to pass on the project?
So I wasn't consulted in that decision making in the run up to the during the decisions of the change from positive to balanced or negative. I was involved in the decision to return to a positive pressure environment, and part of the driver behind that was the direction that we'd been given by Scottish Government that the hospital wouldn't open without being a compliant design.
So you say that obviously you're acting in the capacity of the lead infection prevention control doctor. You're not involved in the decision in relation to balanced and negative pressure and 4 air changes per hour in critical care rooms?
Not directly, no. I wasn't involved in the project as part of the project team. One of my colleagues was accessible for discussions about infection control matters as the site infection control doctor. And we had an infection control nurse dedicated to the project as well. So not every decision would come to me.
Lindsay Guthrie, in her evidence, described as feeling that infection prevention and control were perhaps on the periphery of some decisions that were being made in relation to the project for the Royal Hospital for Children and Young People. Was that your perception as well?
So I was one step removed because we had a nurse and a consultant microbiologist working more closely with the project team. I think I would be consulted and involved when there were issues which either a second opinion or another perspective maybe being sought. But that was usually at the request of the project team rather than me knowing that there might be an issue in intervening.
Because obviously, if you're not being consulted, you don't know what decisions are being made. I think what I'd really be interested in terms of your observations is, in terms of the problems that arose on the project for the Royal Hospital for Children and Young People in the Department for Clinical Neurosciences, do you think that arose because on the part of NHS Lothian they had inept or non-existent risk management because they hadn't involved you in some of the key decisions?
No, I wouldn't say there was ineptitude. I think appropriate disciplines were involved in decision making. I think there was potential issues that guidance was changing through the lifespan of the project. Within critical care, for instance, the original design brief had been discussed with colleagues and was complete by beginning of 2013.
So is the real problem from your perspective just the complexity and difficulty of applying the guidance that was in place at the relevant times?
Certainly there's complexity in the application, but the application can also be influenced by what the priority is at the time. So the driver behind asking for that change in ventilation parameters was being driven by a wish to be able to contain respiratory viral infection. And the principles to do that were sound, and that has been borne out during the COVID pandemic. So, I would disagree that there was ineptitude.
So again, we'll come on and look at this in a bit more detail in relation to the project itself. But if you had been consulted in relation to what the ventilation parameters were for critical care rooms within the Royal Hospital for Children and Young People, would that have been a simple, easy decision that you'd have said, it's absolutely obvious, it's positive pressure and it's 10 air changes per hour? Or actually is it a difficult, nuanced decision as to whether it should be balanced and negative and a lower number of air changes per hour?
I think it's a complex conversation to have, because you can look at this from the perspective of compliance with a guidance document that's considered best practice, and you can look at it potentially from the perspective of the case mix of patients that you're anticipating using the area, and those two things may not align. I key to getting a successful outcome is involving people with the appropriate skills to guide through that process. And infection control has some of that skill, but not the whole skill set. The clinical team has some of the skill, but not the whole skill set. But more importantly, a key participant would be an authorising engineer who will undoubtedly have experience of the potential consequences of deviating from guidance.
So again, just so I'm understanding correctly, it's actually, although there's guidance, that isn't a hermetically sealed black box that if you comply with the guidance, it will always be safe. It's actually a much more nuanced, individualised consideration as to whether something will be safe or unsafe.
Yes, because as we spoke earlier, safety is on a spectrum and can vary depending on the needs of or the state of the patient.
And that's a conversation that needs to take place, as I understand your evidence, between clinicians, infection prevention and control, and engineers to get the right package for any individual space within a hospital.
I would consider that the best model.
Thank you. If I can ask you to look on, still within the 2007 version of SHFN, to page 576, please. And to paragraph 5.19. Beginning, the integration of prevention. Do you see that?
Yes.
And it states, the integration of prevention and control of infection risk management and construction is in its infancy. It represents a significant change in the management of healthcare facilities design and planning, which will take time to develop to a level at which the greatest benefits can be achieved. Just as important then is the need to carry out research in the area of risk management, prevention and control of infection in the built environment to produce sound, irrefutable evidence on which to base further risk management strategies. Do you see that?
Yes.
And is that effectively just encapsulating in the guidance what you told us in evidence earlier today, that this was really an emerging discipline through the 2000s? There was the 1970s research by Dr. Lidwell, but there was still a need, certainly at this point in time, for further research to be done so that there could be the robust, irrefutable evidence upon which to base clinical risk decisions.
Yes, it's a journey that's influenced by changes in how healthcare is delivered as much as the facilities that it's delivered in.
Thank you. And again, just to assist the chair in terms of where matters stood in relation to that research, If I could ask you to look to bundle 3, please, and to page 142. Bundle 3, page 142.
Thank you.
It's just for your observations on the board minute. This isn't a meeting that you were at, but it's a meeting of the Oversight Board, which you'll see on the second line, was held on the 29th of August 2019. There's a range of individuals attend. So Dr. Calderwood, the Chief Medical Officer from the Scottish Government, you see that she's listed as present. Present by telephone is Professor McMahon, the Nurse Director at NHSL, Dr. Gregory Smith, the Chief Medical Officer of the Scottish Government. In attendance is Mr. James, the Director of Health Facilities Scotland, and in attendance by telephone is Professor Riley, the Lead Consultant Infection Prevention and Control for Health Protection Scotland. Do you see that?
Yes.
So a range of individuals with a range of skill sets. And then if we look on to page 144, you see that there's a summary of a discussion that took place on ventilation-specific points. Do you see that?
Yes.
So 1 states, literature review now complete, demonstrated limited and suboptimal evidence around air changes and clinical outcomes. Most evidence had been expert opinion, modelling and outbreak report. Do you see that?
Yes.
And again, just thinking back to 2019, so pre the COVID pandemic, was that your understanding of effectively the evidence base, the evidence base around air changes and clinical outcomes, that was what's described here as suboptimal? Is that a statement that you'd agree with?
To a degree, yes. It's a very difficult area to research because there's so many other factors that influence outcome. There were some key individuals who are certainly closer to the literature than I am regarding that, but a lot of infection control literature and guidance does unfortunately get based on expert opinion and anecdotal experience during outbreaks.
And again, the inquiry's heard evidence that there's perhaps good reason for that, ethical reasons why, if you know 10 air changes is safe, there could be ethical issues in terms of testing that on individual patients at 9, 8, 7, 6 to try and work out what is and is not safe. Is that your understanding of one of the difficulties around about the research in this area?
Well, that's one of the difficulties, but it's very difficult to control for other factors, such as immunosuppression or susceptibility of the patients, and case mix, whether you're dealing with adults or children or neonates.
Thank you. And then if we could return to the minute, bundle 3, page 144, you see paragraph 4, which states air changes is not a specific hurdle to get over, but is the level generally found to be suitable in the majority of developed countries. Do you see that?
Yes.
So I'm assuming this is reference to the guidance in terms of the table with various criteria, and it's saying that air changes in and of itself is just one hurdle, but these are generally accepted parameters throughout the developed world. Is that your understanding from the literature reviews that you've done?
Yes, there are this guidance similar to UK guidance in the USA and Australia, and the numbers aren't necessarily exactly the same for different ward areas, but generally they're on a par with each other.
Thank you. And then just point 6, I'd be interested in your observations. It states air changes are covered by guidance, not standards. Do you see that?
Yes.
Do you think in terms of ventilation parameters for hospitals that it's really good enough just simply to have this loose guidance that should generally be followed, but there's no particular consequences if you don't? Do you think there should actually be a hard-edged standard that should be achieved for new build hospital buildings? I'm not talking about refurbishing old buildings, but I'm talking about new builds. Should there actually be a minimum legal standard that requires to be met for these systems as opposed to a looser concept of guidance?
That may be one way of improving the current situation. I think it would be perhaps stricter than would be necessary in all scenarios. I think if you had areas that were served by critical ventilation systems, it would be perhaps be more useful than areas that don't really have much requirement for such a level of ventilation delivery. So laboratories, for instance, being very different to an outpatient department.
Thank you. And then just while we're on this chapter of your evidence, there's just two more documents I'd like to look at. The first is Bundle 7, Volume 1 at page 342. So Bundle 7, Volume 1, page 342. And this is a minute of a meeting held on the 15th of July 2019. A range of individuals from NHS Lothian are present. You'll see including yourself listed as being present. And if we could look on to page 343, you see that there's a bold heading, critical care design. Do you see that?
Yes.
And then if we look over the page onto page 344, you see the penultimate paragraph begins Tim Davison. Do you see that?
Yes.
If we could look 4 lines down, you see there's a sentence beginning HFS we're still considering. Do you see that?
Yes.
So the minute says HFS were still considering their position and how they could make a pronouncement in respect of whether the facility was safe for occupation or not. Lindsay Guthrie provided an update on discussions with UK experts in ventilation. This discussion had focused on the science around the determination of the number of air changers required per hour, with it being noted that, as previously discussed, these decisions were not scientifically based. Do you see that?
Yes.
So again, as someone working in this space, you're obviously having to make difficult decisions, but these are judgments that you're making as opposed to making decisions based on clear, crisp scientific data. Is that correct?
For ourselves in Edinburgh, we certainly weren't experts in healthcare ventilation, although we'd had some training. So Lindsay had fortuitously had opportunity to undergo that training the week before with UK experts, Malcolm Thomas and Peter Hoffman, and was relaying that fresh training into the conversation locally, whereas my training was a few years earlier, so hers was more contemporary. But yes, it was a complex discussion, and seeking the opinion of folk who are more familiar with those discussions and more experience in other healthcare buildings.
Thank you. And if we just read on in the minute, we'll see what some of that guidance was. It says, a discussion was held in respect of pressure cascades and airflows in terms of providing a comfortable environment as well as the control of infection. In conclusion, it was agreed that the specification of 4 to 6 air changes per hour was an arbitrary number. Do you see that?
Yes.
So again, I'd just be interested in your views in terms of the numbers that we see within the guidance. Should the inquiry understand that they are really arbitrary numbers? They're best practice and a judgment, but there's not really any crisp scientific underpinning to the figures that we see within the guidance.
I am perhaps not the best person to ask that question to. I think somebody who wrote the guidance may be able to answer it more completely.
But certainly, if we look to this minute, this is the discussion that's taking place. So this would be the understanding from a discussion with those experts. I think you mentioned Peter Hoffman of Public Health England, is that correct? And Malcolm Thomas, an engineer.
Yes.
And just to complete the minute, it says other aspects had to be considered, like requirements in respect of protecting staff, where the statutory position was 3 air changes per hour. It was noted that the Roodlands endoscopy unit operated on a 15 air changes per hour basis. Ian Graham advised that work was underway to check the regime that was in place, and there would be a need to come back on this. Do you see that?
Yes.
So again, obviously, it seems like there's difficult, complex discussions taking place. Again, a difficult judgment if you're going to depart from the guidance. how far you can depart from it before matters would become unsafe in any specific clinical space for any specific patient?
Yes, and at that time, it was very much a hypothetical discussion, whereas within a year or so, with the pandemic and the first wave, there was much more experiential learning, I guess, of what can happen if you do try to deliver healthcare with 3 air changes per hour.
And again, it would just perhaps be helpful if you could draw on that experience and explain to the inquiry what were some of the things that professionals working during the pandemic found out could happen if you do depart from the guidance.
So I think the key concern was secondary cases of COVID occurring amongst patients and staff in areas that were that had low ventilation, so areas that were naturally ventilated, and generally areas that had less than 6 air changes per hour were deemed to be suboptimal to prevent COVID transmission. Through the pandemic, the concept of aerosol generating procedures became much more crystallized as a key parameter to consider. So an aerosol generating procedure, there was a list generated nationally by Group Nerve Tag, and there was a lot of debate as to what was and what wasn't aerosol generating. But a lot of the theory that we've discussed already about air changes is based on a simulation where you have a finite release of aerosol in an empty room. So there's a start point, there's an end point, there's a starting concentration and an ending concentration. But what became very quickly apparent was that a number of procedures during delivery of critical care don't fit into that scenario, because you have a continuous release of aerosol from interventions that are potentially life-sustaining. So high-flow nasal oxygen, which along with continuous positive airway pressure are preferred ways of trying to ventilate patients rather than put endotracheal tubes down into their lungs. If you're doing that on somebody who's excreting virus in their throat, you will aerosolize that virus into the room. And if there are multiple patients doing that at the same time, you will generate a very hazardous environment for staff to work in, with accumulation potentially of virus over time. So if the ventilation air change rates are low, what you create is an environment where the staff are entirely dependent on personal protective equipment. Whereas if the air change rates were much higher, then you can protect your staff by nature of engineering out that potential hazard. It's not a hazard to the patients, because generally you will have predetermined everybody has COVID, and if you've already got COVID, you can't catch it from the person in the bed next to you who's got COVID, because you've already got it. But the risk very much was more of a staff safety issue.
And in terms of air changes per hour,
Yes.
is it the higher the number, the quicker that you're removing the contaminant from the space, or how does that work?
So it's not linear in that each air change removes about, I think it's 63% of suspended particles, droplets, aerosols. But the more frequently you do that, the more virus you remove, essentially. But if you're producing aerosols at a faster rate than you're removing them, then inevitably you'll get build-up of virus in that space, because generally there's nowhere else for it to go other than the extract ventilation and a little bit of leakage at the door.
So it's not as simple as saying you would get to a point, if you just kept increasing the air changes, that you would get more and more and more benefit from it. There's a limit to how much benefit will be achieved after a certain number of air changes. Is that correct?
I don't know the physics of it, to be honest, to explain that, but there would be other practical considerations in that you may not be able to deliver that through an air handling unit. There'll be a limitation as to what the capacity of the air handling unit can deliver, the ductwork, what it can deliver.
Thank you. And then just the final document to look at in terms of the scientific knowledge as at around 2019. If I could ask you to look to bundle 3, please, page 185. So bundle 3, page 185. You see this is a report by NHS, National Services Scotland. And it's a review of water, ventilation, draining and plumage systems relating to the Royal Hospital for Children and Young People and the Department of Clinical Neurosciences. If I can ask you to look on, please, to page 199. And to paragraph 4.2.6. Do you see that?
Yes.
Which states, from an infection prevention and control perspective, there is low quality to no evidence from outbreak reports and current guidance, respectively, to support minimum ventilation requirements. Therefore, it is not possible to make conclusive statements regarding the individual minimum ventilation parameters for inpatient care areas. A rapid review of the literature found limited clinical evidence to directly implicate air change rates alone in having a direct impact on the development of an outbreak or incidence of infection. Therefore, it is reasonable that, in the absence of evidence, healthcare design teams should continue to adhere to current national guidance. In the event of a deviation from the current recommended ventilation parameters, design teams should ensure that air changes per hour are maintained as close as possible to the recommended air changes per hour without compromising other aspects of the ventilation system requirements. In addition, a full assessment of the services and patient population should be carried out and mechanisms for monitoring established. Caution is advised in relying on air change rates alone to provide adequate protection from infection. This is only one part of a multifactorial process involved in creating the appropriate airflow patterns with appropriate mixing and dilution of contaminants. Nationally, further research is required to look beyond air change rates to examine the effects that other factors such as supply and exhaust location, door position and motion, spatial orientation, surface composition, temperature, humidity and air distribution patterns have on particle migration in clinical areas. Do you see that?
Yes.
We'll come on and look at some of the decision making in relation to the Royal Hospital for Children and Young People and some of the potential difficulties. But is that quite a crisp summary of the scientific foundation and some of the difficulties that anyone working in infection prevention and control would have if you're looking to depart from what is published best practice for ventilation requirements?
Yes, I would agree with that.
Thank you. We've talked a little about the old Royal Hospital for Children at Sheens. And again, as I picked you up, you said that your understanding was it didn't comply with the published guidance, didn't have any mechanical ventilation, but it was still safe. You didn't have any concerns about children being treated within that hospital. Is that correct?
Yes, so I didn't work at Sheens during my time at Lothian, although I had spent time there as a medical student. But there were systems in place to monitor outcomes, and nationally in paediatric intensive care. There's a group called Paediatric Intensive Care Audit Network who look at outcomes across all paediatric ITUs, look for evidence of harm, mortality, unexpected extubation incidents. And it was, the Sheens department was not an outlier. locally within the department, they had looked to use the Scottish Patient Safety Programme to monitor and perform surveillance on hospital-acquired infection rates for things like ventilator-associated pneumonia or intravenous line infections. So locally, there was some work going on there, and they were not causing concern that they were seeing greater than they would expect to see. So it was determined safe from those parameters.
So again, this will be relevant when we come on and look at the pause in the project. From your perspective as an infection prevention control doctor, albeit not working directly at Sheen's, your understanding was that there wasn't a safety issue around about children being treated within the critical care department at Sheen's?
Yeah, that was my understanding. The department was certainly not optimally designed for the delivery of intensive care treatment because it was a Victorian building, but the outcomes were not of any concern.
Thank you. So that's, if you like, the Children's Hospital. What about the Department for Clinical Neurosciences? If we think back to 2019, was it completely safe?
No.
What, from your perspective, were some of the problems with the Department for Clinical Neurosciences?
So from around February 2019, I was alerted by colleagues from who had been working over the weekend that there'd been cases of Pseudomonas aeruginosa infection in patients who had undergone neurosurgical procedures, which was unusual. We wouldn't normally see that organism in that context. That led to us performing water quality assessment in the building as directed by draft guidance from Health Protection Scotland at the time. And we began to uncover that the water system in that building was quite heavily contaminated with Pseudomonas aeruginosa.
And for those of us that don't work in that space, how significant an issue is that?
So in this particular patient group, our concern was that it was leading to post-operative brain infection.
So should the inquiry understand that the water system at the old Department for Clinical Neurosciences, was that adversely impacting on patient safety and care?
Yes.
So how urgent was it for the Department for Clinical Neurosciences to move from that unsafe hospital to a new safe hospital?
So the incident management team for that incident was attempting to mitigate the hazard presented by putting filters on water outlets throughout the building and stripping out plumbing essentially that was heavily contaminated and replacing it with new plumbing. So there was substantial building work going on in the building. One of the issues with a contaminated water system with this type of organism is that it's not a stable system, it's dynamic, and the organisms can move around the building by means of the pipework. And we would find that as soon as we managed to get areas clear, it would crop up elsewhere in the building. One of the areas that was significantly affected was the high dependency unit. We reached a stage where really apart from the operating theatres, the 3 wards in that building were affected. We had to take showers out of use, toilet areas out of use. It was an inconvenience for patients. And ultimately, we were looking towards moving the department as a control measure because we didn't feel that we had anything other than short-term measures in place, and there was every possibility that harm could still occur.
So we'll come on and look at this, but there is obviously a period where the new hospital doesn't open, including the Department for Clinical Neurosciences, and there's quite a period before the move takes place. Can you just explain in your own words some of the real life critical issues that that's creating from an infection prevention and control perspective?
So at that stage, the issue at the Western had become public knowledge. There was media interest. It was being reported in the BBC. There was the day-to-day issues of where do we consider safe? If it was safe last week, is it still safe? There was a great deal of water testing going on, and the results of that would be coming back from an external water safety laboratory. So that would require time to assimilate and contextualize and identify which outlets were still a problem that might not have risk mitigation. There was a lot of administration related to incidents like this to maintain minutes and record keeping and escalation to Health Protection Scotland as it was. At that time, I was in the role of the site infection control doctor for the Western General, as well as the lead infection control doctor in the Health Board. So a lot of my time was required addressing that issue on the Western site. The executive directors were incredibly helpful, and in fact, given the gravity of what was happening, they took over the chairmanship of the incident in order to free myself and Lindsay up to deal more with the operational management of the incident.
And what impact, if any, did that have on things like clinical capacity and the amount of treatment that could take place within the facility?
I would have to look back at the minutes of the incident to refresh my memory of it. There were, as I say, limits on access to toilet facilities and shower facilities. I don't recall if we'd had to limit surgery. If we did, we would have tried to minimise that as much as possible. By the summer of 2019, prior to July 2019, we started to discover a similar issue in the Western General Intensive Care Unit, which is a different building with a different water system. But that intensive care unit would often manage the post-operative neurosurgical patients who require intensive care. And that started to impact on number of bed spaces available in one of our main adult intensive care units. So it did start to create operational impact.
So should the inquiry understand, certainly from the perspective of the Department for Clinical Neurosciences, there are incredibly serious issues with the built environment, and there is a real pressing need for the new hospital to be open and operational?
Yes, we were, as I say, working towards being able to move the department, which would have improved safety for the patients on the assumption that the new area was free of that organism, and the water system was a fully functional water system. It would have also helped because the plan had always been that the neurosurgical adult patients would go to the Royal Infirmary Intensive Care Unit for management. So by moving, it would free up large capacity in the adult intensive care unit at the Western General to allow some radical replumbing and removal of pipework.
Thank you. Lord Bury, I'm conscious that we're slightly after 11:30. Now might be an appropriate time to take a break.
As I said at the beginning of the morning, we usually take a coffee break. So if we could be back for 10 to 12?
Sure.
Drew, do you want to? Doctor? Mr. McGregor.
Thank you. If I could ask you to have in front of you, please, bundle 1, page 2263. So bundle 1, page 2263.
Thank you.
Which should be STHM 0301, and it's the interim version, the February 2002 version. Do you see that?
Yes.
Sorry, 2022 version. If we just look on, please, to page 2431. You see that there's an appendix 2, so page 2431. You see there's an appendix 2, summary of design conditions. Do you see that?
Yes.
Now, there's some changes to this table from the old table A1 within the 2014 guidance. If we just look to the left-hand side, the application, you'll see that there's general ward level 0 and 1 care. Do you see that?
Sorry, could you repeat that?
So if we look to appendix 2, you'll see in the far left-hand corner it says application, and then below that there's, for example, a general ward level 0 and 1 care. Do you see that?
Yes.
And then if we look 3 or 4 entries down, we'll see there's entries for infectious diseases isolation room, neutropenic patient ward, and we also have critical care areas level 2 and 3 care. Do you see that?
Yes.
So effectively, the general ward now has level 0 and 1 care specified, and then critical care has levels 2 and 3 care specified. And if we look on to page 2487, those concepts are designed. So page 2487, at the very bottom, you see the final entries there are level 0 care and level 1 care.
Yes.
And then over the page onto page 2488, we've got the definitions of level 2 care and level 3 care. Do you see that?
Yes.
So level 2 care being patients requiring more detailed observation or intervention, including support for a single failing organ system or post-operative care, and those stepping down from higher levels of care. And level 3, patients requiring advanced respiratory support alone or monitoring and support for 2 or more organ systems. This level includes all complex patients requiring support for multi-organ failure. Although we see more specification there in terms of the general wards are just level 0 and level 1, critical care being levels 2 and level 3. Is that really an innovation from an infection prevention and control perspective, or would the patients that were residing and being treated in critical care always be patients that were receiving level 2 and level 3 care?
Yeah, so I don't think it's an innovation for infection control. I think patient management hasn't changed. These are distinctions that are fairly familiar to folk working in medicine and surgery. I think it's difficult. Well, you wouldn't, if you were working in a general ward, you wouldn't confuse it with a critical care unit. There's different skill mix, there's different training, there's different equipment, and generally they're located in different parts of the hospital.
So perhaps from a clinician's perspective in infection prevention and control, that's not an innovation, but perhaps if you were an engineer or an estates person, it may do no harm to have that extra level of clarity.
Maybe additional information that's helpful.
But certainly from your perspective, the inquiry should understand that, yes, there's more specification, but you're not reading that as any material change from the 2014 guidance to the 2022 guidance.
Not specifically, no.
Okay, thank you. Now, I won't come to it at the moment, but within the 2022 guidance, there's the concept of the ventilation safety group. If you're derogating from guidance, that's the type of decision that would be made by the ventilation safety group. In either the 2014 guidance or the 2022 guidance, are you aware of any specific standard procedure or standard form that would be completed if there was a derogation taking place from the guidance?
Not in relation to the guidance, no.
Okay. And from your perspective, working as an infection prevention and control doctor, is that problematic in that the NHS as an organisation hasn't provided a standard form template in terms of exactly what would be expected of you if you were thinking of derogating from guidance?
It's an impediment, yes. I think with any system, if there isn't a standard way of doing it, then you risk different outcomes at the end of the process. I think from an infection control perspective, what is useful is having some kind of compendium of what all the derogations are and the content of them, what's actually been decided. The process of how you get to the agreement is more really the project team's remit.
But again, should didn't quite understand from your perspective, if there was a standard set procedure, standard expectations, standard form, that's an innovation that you would welcome.
Yes, it helps in the determination of what the infection risk is.
Thank you. I want to move on now from looking at the effectively guidance and general concepts and now look at the specific involvement that you had on the Royal Hospital for Children and Young People and the Department for Clinical Neuroscience. I'll just refer to that as the project, but anytime I'm referring to the project, that's what I'm referring to. Now, you tell us within your statement that you joined NHS Lothian in 2014 and the project's already well established at that point. Jeanette Rayner-Richards is the infection prevention control nurse that's providing day-to-day help to the project team. And at this point, really, are you arm's length available if required, but really arm's length from the day-to-day project?
Only after October 2015. The first year that I was in NHS Lothian, I had no remit for infection control. Okay.
So 2014 to 2015, no remit. 2015 onwards, you're available but not involved in the day-to-day activities, is that correct? And then at what point do you come into the project and it really becomes almost a full-time job for you?
So that is around about February, March 2019.
So if we think of the period where you are available to be called upon, so that the period from 2015 to 2019, were you aware of potential emerging issues relating to the Queen Elizabeth University Hospital?
Yes.
So you can just explain in your own terms. We'll come on and look at some specific emails that you have in relation to that. But just as a matter of generality, when does that come onto your radar and how does it come onto your radar?
So I think looking back, the initial signals that there were issues was around about 2016 from infection control doctor colleagues in Glasgow reaching out to colleagues in other health boards for advice. It wasn't immediately clear why they were asking those questions. But as time went on, it became more apparent that there were issues with the water systems, or I guess alleged issues with the water systems. And that was more around 2018, where within the microbiology community, word had kind of got out that there were issues with an organism, Cuprivadis, that people really weren't that familiar with. And so there was an interest into what's the issue, where's it coming from. I also had some insight because of work that I was doing as part of the Scottish Mycobacterial Reference Laboratory. I had sessions covering that laboratory, and there were isolates of a mycobacterium being sent to us from the Queen Elizabeth from patient cases that were unusual. So there were some signals coming professionally as well as through the infection control community. I think it wasn't really until kind of December 2018, January 2019, when the media was reporting on cases of Cryptococcus that there was really a release of information about the water systems and the types of organisms that had been seen, and that provided a bit more information about context. Up until that point, I really hadn't had much direct contact with people working in Glasgow. I knew them because I'd trained in Glasgow, but there wasn't really there hadn't been any forum really to speak to them.
So water issues that you're aware of loosely in the period 2016 to 2018, is that correct?
And ventilation, there'd been questions asked about isolation room design to the ICDs in Scotland from colleagues in Glasgow. So yeah, ventilation and water. So
2016 to 2018, issues being raised by colleagues that you know working at the Queen Elizabeth Hospital with yourself, and I think I picked you up as saying other members of the infection prevention control community, was that correct?
Yes.
So at that point, when individuals working in infection prevention control are raising these concerns and issues with you, is there any formalised procedures whereby those types of issues that are being raised by your colleagues are being formally raised with either yourself or NHS Lothian? And I'm thinking particularly Health Facilities Scotland, Health Protection Scotland. Is there any formalised knowledge sharing forum that's happening?
As I say, not until probably December 2018, when there was a Health Protection Scotland report on water contamination at Queen Elizabeth. I don't recall anything earlier than that officially.
So in the period up to 2018, in relation to ventilation, is there any formal communications coming out from Health Facilities Scotland, Health Protection Scotland, or any other central NHS body?
Not that I recall.
And you say you don't recall anything similar for water, I think, until late 2018, early 2019, is that correct?
Yeah.
And is that a report that's being made available to you specifically through a set forum, or is that simply a report that's published that you become aware of?
It had been published on a website, I can't remember which website, and we downloaded it from there. It didn't become circulated around the Scottish Microbiology and Virology Network until August, is my recollection.
To an outsider who doesn't work in the space, it might seem somewhat strange that you have a hospital being built in Glasgow with clinicians that think there are emerging issues, and you've got another hospital being built an hour along the motorway, and that there's not any joined up forum or centralised provision for knowledge sharing between the two. Is that your understanding of the position, that there wasn't any sort of formalised mechanism for sharing and learning from each of the two projects?
Not centrally, but sometimes that's the case in infection control, that incidents, even if they're unrelated to the built environment, information isn't easily shared between health boards.
Do you think it's problematic that there wasn't some form of formalised structure for sharing knowledge and perhaps learning lessons?
Yes, it's an impediment. It would help to have some kind of repository of being able to say, has anybody else dealt with this, and what context it was dealt with. At that time, there was the ability to do that informally amongst colleagues. There was an informal email group of infection control doctors in Scotland, and we would often contact each other about odd things that we were seeing or stuff that we wouldn't normally have to deal with but knew that somebody else had dealt with it.
So the informal group exists, which is no doubt incredibly helpful, but if you describe the lack of a centralised, formalised process as being an impediment, if that impediment was being removed, what system should there be there to try and improve matters in the future?
I think that's difficult to answer. I think some kind of repository of or database. But a lot of the information I would imagine would need to be redacted but some way of communicating, I guess, what's corporate memory for NHS Scotland with regard to incidents.
So some form of formalised procedure whereby issues that are being spotted by particular infection prevention control doctors could be logged and recorded, so that if there are other infection prevention control doctors within other health boards experiencing similar issues, that they could access that knowledge bank.
Yes.
Thank you. And just in relation, I think, to the knowledge that you had on the Queen Elizabeth University Hospital, if I could just ask you to bundle 13, please, volume 3, and to page 462. And it's the email just over halfway down the page, dated the 27th of March 2019. You see that's an email from yourself, Donald Inverarity, to Sarah Jane Sutherland, copying in Lindsay Guthrie. Do you see that?
Yes.
So this is an email dated the 27th of March 2019, and it's really the final paragraph there. You say, I'd been speaking to some of the ID consultants at the QEUH. Can you recall who were the ID consultants of the QEUH that you were speaking to?
So on the previous day, there'd been a meeting of the Scottish Health Protection Network High Consequence Infectious Disease Preparedness Group, which met at Stirling University, and I was attending that, representing the infection control doctors in Scotland and also microbiology laboratories for the SMVN. There were representatives from various health boards, the ambulance service, who would deal with, I suppose the reason for the day was scoping out how is Scotland prepared if there was something like Ebola imported. The chair of that group is Professor Tom Evans, who's an infectious disease physician in Glasgow. I don't recall whether it was Tom or other ID consultants that I'd spoken with, but they had, just over sandwiches, we ended up discussing about isolation rooms because it was relevant to the day, and it'd come to light that there had been problems with the isolation rooms in the new QEUH.
Okay. So you tell us in the emails, I've been speaking to some of the ID consultants at QEUH and the Glasgow Children's Hospital yesterday, and they explained that all their isolation rooms were being refitted as the original design didn't seem to provide appropriate pressures and airflows when the rooms were occupied. Do you see that?
Yes.
So again, should the inquiry understand, first quarter of 2019, you are aware that certainly colleagues are telling you that there's problems with the pressures and airflows in certain rooms within the Queen Elizabeth University Hospital?
Yes, it was second-hand verbal information.
Okay. And just in relation to the chronology of the project and your involvement, the inquiries heard evidence that during 2017, there was effectively a dispute that arose between NHS Lothian on one side and the project company IHSL and their contractor Multiplex on the other, in relation to what pressure regime and potentially air changes should be taking place within certain rooms within the hospital. And it transpired that some of those rooms were within the critical care department. Should the inquiry understand that really 2017 through 2018, that's not an issue you're aware of or you're specifically advising the project team on?
I had some awareness of it from Jeanette about the fact that the 4 bedded rooms in general wards were designed at positive pressure. There'd been email correspondence with Ronnie Henderson and the project team trying to establish what would be the best pressure cascade for those rooms. But it was in the context of general wards that I had an awareness. I had no knowledge of the dispute.
So you're having a discussion with a colleague who's telling you there's a dispute over certain ventilation requirements for 4-bedded rooms. But as you understood it, that's a discussion about general wards as opposed to any area of the hospital that would require specialised ventilation, such as critical care rooms.
Yes, that's correct.
Thank you. And perhaps just to put that in context, if I could ask you to have in front of you, please, Bundle 13, Volume 7, page 37. So Bundle 13, Volume 7, page 37.
Thank you.
Now, these aren't email exchanges that you're involved in, but I think they might reference the discussion that you said that you were having with Jeanette Richards. So the first one, well, perhaps if we just pick up the penultimate email on that page from Ronnie Henderson to Jeanette Richards on the 20th of January 2017 at 12:53. Do you see that?
Yes.
It says, "Hi Jeanette, that's just it. It doesn't, there's some dubiety over a couple of things. One, can a 4-bed bay be described as a general ward? 2, if so, what is the pressure relationship to the corridor, as there's just a dash in the box on the table you attach? I'm looking for infection control's take on a scenario such as if 4 patients with infection status unknown are in the room, and what way do you want the air to go? To the room from the corridor or to the corridor from the room?" Do you see that?
Yes.
And then the response comes in, the email above from Jeanette Richards to Ronnie Henderson on the 23rd of January 2017, where she says, "The 4-bedded rooms are considered to be the general ward." Do you see that?
Yes.
She continues, "As you're aware, each 4-bedded bay has an ensuite toilet, neg extract, and an ensuite shower, neg extract." Do you see that?
Yes.
Now, from an infection or a clinician's and/or an infection prevention and control perspective, is the references to ensuite bathrooms, is that of any relevance if we're talking between a general ward and critical care?
Yes.
And can you just explain why is that significant?
Well, in a general ward, patients are what would be termed ambulatory. They can walk, they can get to the toilet themselves and perform personal hygiene themselves. So there's a need to provide a toilet and usually a shower within walking distance of that room, if not within the room itself. Nowadays, it's generally within the room. In critical care, the patients are often either unconscious or sedated or connected to so many machines that they wouldn't leave the bed. So there are very, very few scenarios where a patient in critical care would be using a toilet.
Thank you. And if we just look back to Bundle 13, Volume 7, page 37, it continues, "Should we get to that scenario that all sink cubicles are full and we have 4 cohorted patients in a 4-bedded bay, then yes, we would want to ensure all infectious organisms are maintained in the room, which yes shows that neg pressure in the 4-bedded areas is of benefit. Our contact at Mott MacDonald will probably be able to advise, as will Ian Storer at HFS, if this communication is not clear enough." Do you see that?
Yes.
So in terms of the advice Jeanette Richards is giving, 4-bedded bay, general ward, negative pressure, is that fully in compliance with the guidance set out within SHTM 0301 2014?
So I think as is being discussed here, there isn't a clear parameter in the general ward for the pressure cascade. In other examples in that column, it would have a plus or positive or negative, but there's just a hyphen for general ward. So from the table, I think there's ambiguity. I think, though, there's sometimes a danger that folk get fixated on the how to build it and forget why you're building it. And in a 4-bedded general ward area, it's fairly common every winter to have folk with norovirus suddenly vomit in a ward. You would want to have an environment that tries to contain that in the room, not just from an infection perspective, but also from an odour perspective, because if there's vomiting happening in one bedroom, you don't want that really drifting down the corridor into other bedrooms. So there's a rationale from an infection containment perspective, but just also patient satisfaction, patient comfort, and odour control in having it negative or balanced. But certainly it would be a little bit odd to be positive.
Thank you. And we see there Jeanette Richards saying very clearly that if Mr Henderson needed any further information, that he could contact Mott MacDonald, who at the inquiries heard were the lead technical advisors for the project, or Mr Storer at HFS.
Yes.
See that? Because again, the inquiries heard evidence from 2 infection prevention and control nurses who've said very clearly to the inquiry they're not engineers, and they wouldn't know the specific engineering parameters that were required for any particular space. They can tell you about the clinical issues, they can tell you about infection prevention and control, but if you need the specifics of what you actually do to meet those clinical requirements, that's an issue for the engineers. Is that your understanding of how the demarcation works in the project team?
Yeah, so I guess the boundaries are a little bit blur, but I wouldn't be expecting my nursing colleagues to be providing advice on engineering. They're not trained to do it. Thank you.
So there's this issue which ultimately comes to a dispute between NHS Lothian and IHSL and the project company. Were you aware or advised that there was the potential for litigation to take place between the 2 parties that were in dispute?
I've no recollection of that.
Okay. So in terms of court documents that were drafted, specifics of requirements that had to be met, that's not something in your position as an infection prevention control doctor that the project team were asking you for any advice or input on?
No.
There was the inquiries heard evidence that there was a principals meeting that took place in early 2018 to try to resolve this dispute as to whether the space should be balanced or negative or positive pressure, and a discussion around about associated issues. Were you invited to that principals meeting to provide infection prevention and control advice?
I don't recall being invited.
Thank you. And that then, those discussions ultimately led to a settlement agreement being put in place. Agreement in 2018 on what would be done, with the formal document being signed in February of 2019. Did you have any involvement in the drafting or approval of the technical schedule that went in that document, that settlement agreement?
No, but that wouldn't be my role.
So whose role would that be?
Well, I would imagine it'd be the project team.
And again, just to pick up on your lack of knowledge of the settlement agreement, if I could ask you to have in front of you, please, Bundle 7, Volume 2, page 364. So Bundle 7, Volume 2, page 364. It's just the email at the very bottom of the page from Lindsay Guthrie on the 7th of August 2019, copying a number of people, including yourself.
Thank you.
And then if we look over the page, onto page 365, Ms Guthrie says, "Hi Ian, can I clarify what you would like provided for?" Then if we look to the second bullet point, 3 lines up from the bottom of that paragraph, she states, "As discussed, we were not involved in the settlement agreement or handover. Part 4 of HAI Scribe was begun in May 2019, but not completed pending receipt of satisfactory water and ventilation functionality / sampling from commissioning." Do you see that?
Yes.
So again, your colleague Lindsay Guthrie has as I understand it, I'd welcome your views, effectively saying that infection prevention and control hadn't been involved in the negotiation or signing of the settlement agreement or in completing a Part 4 HEI scribe before May 2019.
That's correct.
So the inquiry's heard evidence that the building was formally handed over to NHS Lothian on the 27th of February 2019 and that no stage 4 HEI scribe had been completed. You obviously didn't know about any of this at the time, but did you subsequently discover that that was what happened?
So my awareness that there'd been handover of the building was through an all-staff email that was to everyone in the organisation.
So you found out through an all-staff communication that the building had been handed over. Can you just tell us in your own words what was going through your head at that point when you found that out?
So surprise. It came before I took a week of annual leave. So there wasn't a lot that I was able to do in terms of supporting colleagues in infection control and raising concerns until I got back. But we were concerned that due process wasn't being followed.
And again, we covered some of this at a general level earlier in terms of some of the risks of not completing a stage 4 HEI scribe before accepting a new build hospital. Can you just try and explain when you find out that the new hospital's been accepted, no stage 4 HEI scribe, what concerns do you have at the forefront of your mind?
That there was potential risk that had been accepted and we didn't know what it was.
And potentially how serious could those risks be?
Well, at the time, this was along the lines of when we were having the water problems in the West in general, and we also had a complex IMT on one of the other hospital sites as well, that we were looking into ventilation systems as a potential factor, and we didn't have assurance that the water system and the ventilation systems were optimised.
Okay. And you tell us within your statement that you would have expected to see an independent validation report for the ventilation system in particular, is that correct?
Certainly the operating theatres, the isolation rooms were key areas that I needed to know were functioning optimally. In the validation stage for operating theatres, there is a microbiological assessment of air quality as well as an assessment of the performance of the engineering. So I would have expected to have been involved at least in that assessment as the microbiologist.
So albeit due process hadn't been followed, did you have all of the information you needed as a microbiologist to be able to make an assessment of whether this new hospital was safe?
No.
If I could ask you to look, please, to bundle 5, page 35. So bundle 5, page 35. You see that the first email was from Alex McMahon to Jim Crombie. Do you see that?
Yes.
Who's Alex McMahon?
Alex McMahon was the Director of Nursing in NHS Lothian, and at the time was the Executive Lead for Healthcare Acquired Infection.
And we see the email states, I caught up with Donald after the DCN IMT. He said he would send me this email and I have his permission to forward on. For transparency, I've copied Donald in. The content gives me some cause for concern. Do you see that?
Yes.
And then if we look to the content, your email is below that. So this is an email from yourself to Alex McMahon on the 13th of March 2019, where you say, Dear Alex, following our discussion after the DCN IMT today, I'd like to raise a further issue that relates to water quality and ventilation in the new hospital site. Please see the confidential email dialogue attached, which was sent to me by the commissioning team in the week before the building was handed over to NHS Lothian. It was highlighted that there were concerns about pseudomonas and, more concerningly, Legionella in the water. Despite replying expressing concern, particularly over the findings of Legionella, there was no further communication with me about this issue. Do you see that?
Yes.
So you've raised an issue about water quality, and should the inquiry understand that you hadn't had any form of formal response to that?
So the issue had been raised with me by Ronnie Henderson, if I recall correctly, who had shared with me letters between Bouygues and IHSL. And within that, there was a discussion about that there was an outlet in the building where Legionella had been detected, and that there were other outlets where Pseudomonas aeruginosa had been detected. But it wasn't clear where the outlet with Legionella was in the building, and it wasn't clear to me whether that had been addressed or how it had been addressed. So that statement about having no further communication about the issue is in relation to seeking more information about where the Legionella was and what had been done to resolve it.
And this is in the period after late 2018, whereby there were at least emerging issues around potential water quality issues at the Queen Elizabeth University Hospital with, I think you said you'd seen a published report in relation to those issues.
Yes.
So were those issues factoring into your thinking in this email?
Yes, but more so with our present experience with the Pseudomonas in the Western General, in the DCN building, and finding Legionella in water and healthcare should be a never event.
Thank you. And then if we look over the page onto page 36, if we look at approximately 4 lines up from the bottom of that top paragraph, you'll see the wording, "I've never seen any of these validation reports." Do you see that?
That's correct.
"I've never seen any of these validation reports, and neither have any of my consultant microbiologist colleagues, albeit we were given a tour of the ventilation system and theatres as they were being built." Do you see that?
Yes.
So you've been for a tour of the hospital, but in terms of the validation reports that you'd be expecting to see to comply with the requirements of SHTM 0301, you still haven't seen those as at the 13th of March 2019.
That's correct.
Could I ask you to have in front of you, please, Bundle 13, Volume 8 at page 158. So Bundle 13, Volume 8, page 158, and it's the email just over halfway down the page from George Curley to Donald Inverarity on the 25th of February 2019. Do you see that?
Yes.
And it's headed up Glasgow Report on Water Incident at QEUH. And it says, "Hi Donald, yes, I have, and again, many of our proposals in the paper I sent you are based on the Glasgow experience. I was a little hesitant in the paper to cite Glasgow directly, but I guess you can assume it is strongly inferred. However, good that Brian can review this report more fully rather than the potted summary I could share." Do you see that?
Yes.
So that's referring to the publication of the report. Is that the water quality report that you referred to being published in late 2018, early 2019?
Yes.
So up until that document, that water report got published on the website and you managed to download it, was there effectively just inferences being made on the part of individuals working within NHS Lothian that you knew there were potential issues at the Queen Elizabeth University Hospital, but there hadn't been any formal communication from any other NHS bodies in relation to exactly what those issues were.
That's my recollection, yes.
If I could ask you to have in front of you, please, bundle 4, page 8, please. So bundle 4, page 8. There's a letter from the Scottish Government addressed to NHS Chief Executives on the 25th of January 2019. Do you see that?
Yes.
And it states, following my call with you on Tuesday, 22 January, about the ongoing incident at the Queen Elizabeth University Hospital, I said I would write to you with a set of actions following the meeting of the Strategic Facilities Group on Wednesday, 23rd January. Do you see that?
Yes.
Then if we skip to the next paragraph, it says, just above the bullet points, I would like you to confirm are in place and working effectively. And then there's the final bullet point. It says all critical ventilation systems should be inspected and maintained in line with Scottish Health Technical Memoranda 0301, ventilation for healthcare premises. Do you see that?
Yes.
Did you have any awareness of this letter or these types of communications as at January 2019?
Not at the time that they were issued. I was aware of this letter because George Curley, as the Director of Facilities, shared it with me as part of that earlier email trail, where he shared the paper that he was going to present to the Healthcare Governance Committee, I think it was.
Thank you. So just, again, so that the inquiry understands that the timeline correct, there's no dispute that the settlement agreement in relation to the RHCYP, that signed in February of 2019. NHS Lothian in January 2019 is having it raised by the Scottish Government that there's concerns about the Queen Elizabeth University Hospital and a need to make sure that all critical systems are complying with published guidance, including SHTM 0301, known risks about potential issues relating to cryptococcus. Yet, as lead infection prevention control doctor, you're still not involved in any of the discussions prior to that settlement agreement being signed?
Not that I recall.
Albeit the stage 4 HI scribe hadn't been completed before handover, the inquiries heard evidence that some of your colleagues within infection prevention and control tried, albeit retrospectively, to carry out that stage 4 HI scribe. Are you aware of that?
Yes.
And again, we'll come on and look at some of the documentation, but can you just explain your understanding of whether they were able to successfully complete that stage 4 HI scribe?
No, they weren't, because not all questions in the stage 4 apply to every project, but there are two areas which are very explicit about ventilation and water, and I can't off the top of my head remember the exact wording of the statements, but one of them asks whether the water system is compliant with SHTM 0401 and whether the ventilation system as built is built as designed and built is compliant with SHTM 0301. And we couldn't answer those questions because we didn't have anything to evidence them.
So perhaps if we just look to bundle 5, please, page 95. So bundle 5, page 95. This is the HI scribe form. You're not involved in the team that's actually going out and doing the assessment, but it's really just to try and help jog your memory as to what those questions may have asked. And if we could look on, please, to Bundle 5, page 98, and to look, for example, to question 4.26. So 4.26, is the ventilation system designed in accordance with the requirements of SHTM 0301, ventilation in healthcare premises? Do you see that?
Yes.
Again, is that something without an independent validation report that an infection prevention and control specialist could make a determination of?
Not in its entirety. I think there's aspects where we can give an opinion, but the determination of whether it's designed in accordance with 0301 is best performed by an authorising engineer.
Thank you.
It involves understanding the engineering in a way that we aren't trained in.
Thank you. And then we see other questions continue, such as 4.27, is the ventilation system designed so it does not contribute to the spread of infection within the healthcare facility? Do you see that?
Yes.
And your colleagues were unable to complete the stage 4 HI scribe?
Yes.
And did they discuss that matter with you?
Yes. I was on a day off the day that they initially started this process. But Lindsay Guthrie very quickly got in touch to discuss her concerns, and it was a collective decision. I agreed.
So what concerns does she have?
That there wasn't evidence to be able to truthfully complete that statement.
So infection prevention control weren't able to sign off the stage 4 HI scribe, weren't able to say from an infection prevention control perspective that the hospital was safe?
Was compliant with 0301 and by inference, so, yes.
Thank you. So if we could look to Bundle 13, Volume 7, page 110. So Bundle 13, Volume 7, page 110. And this is an email from Lindsay Guthrie to yourself on the 29th of April 2019. Whereby she states, can we have a quick chat about this, please? Sarah and I attended a site visit to complete stage 4 of the scribe on Friday. I wasn't happy to sign off the ventilation or water, given the recent discussions at PLICC or concerns raised without discussion with you first. Do you see that?
Yes.
And what's she referring to by PLICC? Were you aware of any discussions that took place at that?
So that stands for the Pan-Lothian Infection Control Committee, which is a committee of disciplines with NHS Lothian that have input into maintaining prevention of infection. The estates team is one such discipline. My recollection is that she was referring to a meeting where it had been relayed in that committee that there had been a number of snagging issues and non-conformances identified already in the new hospital, but the nature of which wasn't very clear.
Thank you. And you said that you discussed matters and you agreed with Lindsay Guthrie. What did you collectively agree?
That we would not complete the stage 4 high scribe.
And we see that recorded if we look to Bundle 13, Volume 7, page 96. You see this is an email from, in the middle of the page, from Lindsay Guthrie to Janice McKenzie and others. You're copied in on the 13th of May 2019. The final two paragraphs. So page 96. Final two paragraphs. We are also awaiting for more information on approx 86 issues stroke non-conformances ahead of a meeting with George Curley and others on 5th June. We've been advised that many of these issues have been resolved, but currently have no detail in relation to this. I think until we have more information, and as discussed, the IPCT would not be able to provide sign-off and assurance for the board that the building is ready to be occupied by vulnerable patients. Do you see that?
Yes.
So is that effectively just recording what we've already discussed, that the building wasn't fit to be occupied by vulnerable patients, given the lack of documentation?
Yes.
So if we move forward perhaps to the period in May, by the time we get to May, had you and your IPC colleagues received all of the information and documentation that you were expecting?
No.
Can you just explain what's happening in that period then, really sort of up to May 2019? Why aren't you in a position to complete the Stage 4 HEI scribe?
So we being Sarah Sutherland, myself and Alex McMahon, had arranged to physically view the building. And during that walk round, we visited areas where there was already concern. Some of that related to a flood that had happened the previous summer. Some of it related to concerns about the functioning of the operating theatres and isolation rooms, and some of it related to the concerns about the water quality. During that walk round, it became very evident, particularly in the theatres, that they were not in a state where you could perform validation.
And if I can just ask you to look to bundle 6, please, page 6. It's an email exchange beginning at the top from yourself on the 10th of May 2019. Where you say, for information, I'm keen that you're aware of this, as I don't solely represent NHS Lothian with regard to the potential risk associated with this situation. Do you see that?
Yes.
So you're saying that there's potential risk here, but how concerned are you at this point in May 2019 that you still can't complete the HEI scribe process?
I was very concerned because we were aware that the building may be open to patients in July.
So very close to opening for patients, and you're going round looking at operating theatres, and from the evidence you've given, you're thinking this is a long way from being able to open safely for patients.
Correct.
If we look on bundle 6, page 6, to the next email in that chain, which is an email from yourself to Ronnie Henderson on the 10th of May, you state the multiplex document doesn't indicate what size the theatres are, what the air pressures are in the theatre areas, anaesthetic room, prep area, theatre, etc., or what number of air changes per hour are achieved, and neither does it mention what, if any, microbiological assessment of air quality has been performed. That box is blank, so I'm presuming none has been performed. Although you're being assured it conforms, it isn't explicitly stated what standard it conforms to, presumably SHTM 0301. Do you see that?
That's correct.
So is that you highlighting you've received some documentation from the project team, but you don't consider it sufficient to allow you to complete the HEI scribe?
Yes, what Ronnie had shared was a checklist that had a multiplex logo on it, which I had seen a few months earlier from Jackie Sainsbury. If I recall correctly, it was dated October 2018, so it wasn't contemporary. And it was a checklist. It didn't give me data that would tell me how an operating theatre was functioning. And it wasn't really aligned to what SHTM 0301 said about a validation report being clear and indicating that the system was fit for purpose.
So we see the bold text there, so you quote a statement from the information you'd had, and you continue just below the bold text. You say that might be factually correct, but there is nothing to back it up, and it tells us absolutely nothing about how the theatre performs at baseline. It is essentially asking us to taking everything on trust that it's all okay. Do you see that?
Yes.
So were you prepared to just take it on trust and assume that everything was going to be okay?
No.
Then if we look within that paragraph, 3 lines up from the bottom of that paragraph, beginning, but in my role, do you see that?
Yes.
You state, but in my role as infection control doctor, I shouldn't need to go to source documents and extract that information to interrogate and interpret it myself. It should be clearly and explicitly included in the validation report. Do you see that?
Yes.
So what you really wanted was a clear, crisp statement in a validation report of just exactly the levels that the system was performing at.
Yes.
Then if we look still within bundle 6, page 7, to the final paragraph on that page, final paragraph at the bottom. So bundle 6, page, we're still in bundle 6, page 6. It's the final paragraph that trips over onto page 7. Beginning, personally, I don't think. If we could go back to page 6, and it's right at the bottom. You state, personally, I don't think we've been provided with a full report detailing the validation findings, and there's not enough detail for me to know if the theatre is fit for purpose and will only require routine maintenance in order to remain so for its projected life. And then if we look on to page 7, first full paragraph, you say, I'm happy to be overruled, but for me, I'm not assured by this checklist that Theatre 30 is fit for purpose because the information I would be looking for to allow me to have the assurance is not provided and not accessible by me. You see that?
Yes.
Was there further independent testing that the project team agreed to undertake?
Pardon, could you repeat that, please?
Was there further testing then in the period that follows from the 10th of May 2019 that the project team agreed to undertake?
I think that they agreed that they would need to undertake independent validation, but the date of when that began, I believe, wasn't until June.
And was that something that the project team were willing to do, or was it something that they were initially resistant to doing?
I think ultimately that they were willing to do it. I think initially there was a bit of uncertainty as to why I was not accepting that checklist.
Because if we just look down bundle 6, page 11, this is an email of the 13th of May 2019 from Ronnie Henderson to Donald Inverarity. Do you see that?
Yes.
And Mr. Henderson states, as you know through our previous discussions, it is neither our desire nor intention to provide something you are not 100% happy to accept as a suitable record or report. Do you see that?
Yes.
The email goes on to say, if you need this to be done, then it can be done at a cost. It would just be helpful if you could outline the discussions that you were having with Mr. Henderson. And really what I'd like to try and understand is whether this is a genuine collaborative discussion or whether you're trying to be talked out of NHS Lothian having this full independent report that you wanted.
So I think from Ronnie's perspective, he may have been frustrated that I wasn't prepared to look at this system called Zootech to see the actual source information. From my perspective, I, at that time, did not have any capability or margin to learn how to use a new software system to find data. And I think that's where we were coming at different perspectives. I don't think it's evidence of us not working collaboratively, because Ronnie and I had been working collaboratively on this, not necessarily on the ventilation issue, but issue with compliance of the ventilation system in the haematology ward and some design issues there as well since late 2018. So I think this reflects perhaps a frustration that was born out of this being very close to the line, and the implications of having to organise it.
Thank you. So discussions around about whether there has to be the independent testing, ultimate agreement from Mr. Henderson that the testing would take place, albeit given how close you are to the hospital opening, perhaps some frustrations with that on the part of the project team.
Yes.
And I'd be interested in your views if yourself and your colleagues hadn't persisted and said we really do need this independent report, do you think the hospital would have opened?
I think that's a possibility.
The inquiry's heard evidence that an entity called IOM Limited, they come in and do the testing to try and produce the report, and what they find is that the ventilation system for certain critical care spaces doesn't, in their view, fully comply with the requirements of SHTMO 301, because certain of the rooms in critical care don't have positive pressure and 10 air changes per hour. Is that your understanding?
That is correct. Initially, though, they had identified issues with the operating theatres rather than critical care.
So it's an ongoing process with IOM. There's certain issues identified at one stage, more testing and then more issues, but eventually there are these issues identified with the critical care department. Thank you. What happens at that point? So whenever IOM bring back those test results, just talk us through your understanding of what's happening in the project at this point and what's your involvement in general terms. We'll come on and look at all the detail of the emails, but just try and explain to the chair what's happening at this point whenever the IOM report lands.
The IOM report about critical care?
I think just talk us through from the reports in relation to the theatres right through to critical care.
So initially the IOM reporting was with regard to the operating theatres, and in the Children's Hospital, the operating theatres are for paediatric surgery and for neurosurgery. The initial theatre results were indicating that there was not a functional operating theatre in the building that was balanced in the way that we would expect to be able to operate safely. Some of the theatres, there were internal design issues also being identified, such as where the air extract vents were. They'd been built with air extract at high level, and in the theatre it should be at low level. So there were design issues as well as performance issues that were being uncovered. Rectification of those was going to be very difficult to achieve in the time frame permissible for all the theatres. So at executive level, and by this time there was regular meetings with the executive directors and chief executive. There was a plan to try and achieve at least 4 theatres to be in a working state before the 9th of July. And that was 2 paediatric surgery theatres and 2 neurosurgery theatres to allow for capacity for emergency surgery only. That work was commencing while further validation work was happening elsewhere in the building. So there were engineers working on trying to rectify these issues while more new verification data was coming in. And it was about, 1st of July was when the executives and myself and Lindsay Guthrie first saw the data coming in for the critical care unit, which indicated that the 4 PPVL isolation rooms were close to achieving what they were supposed to, but weren't quite. The 4 single rooms did not fit the specification for critical care, and the 4 bedded rooms didn't fit the specification for critical care. So we were then left with the scenario of, if the hospital opened, there may be no critical care unit and only 4 functioning operating theatres, with trauma patients or accident emergency patients coming in the front door, potentially needing surgery and potentially needing life-prolonging, life-saving treatments and critical care.
So at that period, 1st of July, whenever you realised there's these problems in critical care, the hospital was due to open in a matter of days, is that correct?
Yes.
Did you think there was any possibility the hospital was going to open?
It seemed unlikely, given the scale of what was being uncovered.
Thank you. Lord Burley, I'm conscious that's 1 o'clock now. Might be an appropriate time just before I go through the detailed timeline and all the various communications to break for lunch.
Very well. We'll take a lunch break now. So if you could be back for 2 o'clock.
Yes.
Thank you.